Good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from Portugal, Professor Oscar Alves. Professor Alves is the head of neurosurgery at the Hospital Luciaidas Porto. He is a senior consultant in neurosurgery at the Centro Hospitalar de Gaia Espinho. He was a previous Fulbright Fellow and he is a co-chairman of the International Academy of Spine. His clinical interests are focused on spinal diseases including spinal tumors and degenerative spine diseases. We are extremely honored to have him today at our webinars, and today he'll be talking about cervical arthroplasty, present and future. The speaker for the second session of today is our honored guest from China, Prof. Li Ming. Professor Ming is the Associate Professor at the Department of Neurosurgery at the Henan People Provincial Hospital, China. He is Associate Editor-in-Chief of the journal Cancer Translational Medicine. He was a former postdoctoral research fellow at the Department of Neurosurgery at the Mass General, and his research is focused on exploring new methods to improve diagnosis and therapeutic evaluation of brain tumors. We are extremely honored to have him today with us to be a speaker, and he'll be talking about prediction of IDH mutational status in WHO grade 2 and 3 gliomas using hyperintense flaring combined with H1 MRS. The chair for the first session of today is our honorable faculty from USA, Prof. John Shin. He is the Director of Spine Oncology and Spinal Deformity Surgery, Director of Neurosurgery Spine Network, and Co-Director of the Mass General Program Neurosurgery Complex Spine Fellowships. He specializes in complex spinal reconstruction surgery and is an internationally recognized leader in spine surgery. He treats the full spectrum of complex spinal disorders and has particular expertise in the treatment of cervical and lumbar spine deformities and spine tumor surgeries. We are extremely honored to have him today at our webinars, and we are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our honorable guest from the USA, Dr. Ali Reza Manzoori. Dr. Manzoori is an assistant professor in the Department of Neurosurgery at the Penn State Cancer Institute, Pennsylvania, and his clinical interests are focused upon brain cancer trials, surgery of brain tumors, and epilepsy surgery. His literary contribution sums up in scores of international publications and book chapters, and we are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. With that introduction, I would like to hand over this online podium to our first chair, Professor John Shin.
Hello, everyone, and thanks for joining us, and thanks for inviting me and having me for this wonderful webinar educational session. It's a real honor here to be with colleagues from around the world, and I'm really excited to hear what Dr. Alves has to say regarding cervical arthroplasty. He's a well-recognized international leader in neurosurgery and has many leadership positions, including with the Cervical Spine Research Society. And I think that cervical arthroplasty is such an important topic, and regardless of where you practice in the world, I know that at least in the United States, there's increasing interest in this, the clinical applications, the biomechanical background, and the justification for such. And so I think when we have opportunities to learn from experienced leaders, sharing their experiences and bring us up to date on applications of such, I think such are very rewarding. So with that being said, it's my great pleasure and honor to introduce Dr. Alves to speak with us today. Thank you.
Thank you so much for having me. It's a great honor to present on a webinar on the Asian Congress of Neurological Surgeons. So my topic today is on cervical arthroplasty, current and future. I have no disclosures relevant for this presentation. So the first question when you address cervical arthroplasty is why to preserve motion in cervical spine surgery. And cervical spine, from an ontogenetic point of view, is designed for motion more than any other element of segment of the spine. And as you see here in this graph, the significant motion occurs in subaxial spine where degenerative disc disease is more prevalent. What we traditionally do is cervical spine fusion, and what happens at the index level, the fusion construct originates motion loss and stiffness. And if you look at this biomechanics study, arthroplasty shows similar features to an intact segment. Also, if you do it multi-level fusion, you end up just buying more negative biokinematic effects of a single level fusion. You increase the stiffness of the spine, as you see on this comparing single fusion to double fusion. So I think since the beginning, I was interested in this technology. I think it's probably more clinically more meaningful to offer motion preservation when you operate on multi-level disease patients than one level, because adjacent natural levels, they can compensate for the loss of mobility observed with the fusion. This is kind of patients that I see in my office quite often, patients in the mid-40s, mid-50s with myelopathy, radiculopathy, 4-level lesion. One option would be to build such a really rigid construct with fusion. The alternative could be motion preservation, and this is the one I tend to offer to my patients. With a 4-level, for either post-op control, even lateral bending looks very interesting and very nice. So when you do cervical spine fusion, you lose useful motion. And I quite like this study published in European Spine Journal for multi-level anterior cervical fusion and the kind of loss that you have. You can have losses around 25% in sagittal plane, 40% in coronal plane, 25% on horizontal plane. And bending forward is the most affected movement. And if you look at the kind of movements you have to do and the motion that you need for tying shoes, backing up a car, washing hair in the shower, crossing a street, it's really important. And this is the reason why I think, especially in multi-level disease, there is a negative impact on cervical spine global functional status. And if you do it in young patients, it will be very poorly tolerated when you assess quality of life in those patients, especially patients with higher life expectancy. So what are the key points of superiority of arthroplasty regarding fusion? And I have here a kind of shopping list, and I will go from all individual points. And I think clinical outcomes are at least not inferior to fusion. If you look at this meta-analysis, 19 RCT studies, very important number of patients, although a short-term follow-up, TDR was significantly better, NDI success, functional outcomes, neck pain score, overall success, fewer operations at the index level and fewer operations at adjacent level. But if you pull together just the ID studies, and you have here just for a single level, 7 FDA-approved artificial disc studies, you see that the overall success is not inferior, clearly. Some cases superior to fusion. So arthroplasty is the most scrutinized entity in spine surgery. You see level 1 high-quality data across different devices with long-term follow-ups. And I have to say, we expect probably better results because none of these implants are third-generation implants. And prótese design has an implication on biomechanics. You can have fixed core, central rotation devices, mobile core, and the so-called compressible 6 degrees of freedom. Although they have almost similar range of motion, the quality of motion achieved by 6 degrees of freedom prosthesis is much better. In this paper here, looking at different devices, 6 degrees of freedom devices restore near normal cervical kinematics, leading to improvement of outcomes. So green is good, red is not so good. And if you look at the biomechanics of the device that we are using, the likelihood of achieving flexion extension range of motion within the physiological range, which is 5 to 16 degrees, depends on the prosthesis design. And 6 degrees of freedom devices, they have the highest proportion of implanted segments in the physiological motion range compared to the cohort, as you see here, the average cohort. So no doubt, I believe that new studies with newer devices will show even better results. And you see a center of rotation for one of those devices, really comparing intact with the surgery patient, the surgical patient, you see a very close location of the center of rotation. Also, the kinematic signature, if you look at the low displacement curves, these kind of devices, they have a very nice curve that fits almost the intact level. So what about what about adjacent segment preservation? That was the main reason to introduce arthroplasty in the market. Whenever you do a single or a double fusion, you are increasing, there is no doubt, range of motion at the adjacent levels. And this is especially true in the superior level, where you see a significant increase of hypermobility, in this case, after two-level ACDF. But that's not only increasing motion, you are also increasing intradiscal pressure in the adjacent levels. So the combination of increased motion linked with increased intradiscal pressure, this will accelerate the disc degeneration. So clearly, if you do an ACDF, you are doing something that it's not a physiological surgery. And look what's happening while you are aging. While you are aging, your cervical SVA tends to increase. So if you've done fusion, like in this case here, 2-3 level fusion, what's happening is while you increase your cervical SVA with aging, there is a tremendous increase in adjacent disc pressure, so putting more pressure on disc degeneration. So clearly, from a biomechanical point of view, there are many biomechanical and finite element studies that show that fusion has a negative impact on adjacent segment, increased range of motion, changes in the center of rotation, increase in interdiscal pressure, and arthroplasty effectively mitigates many of these negative biomechanical effects. And of course, when you do multi-level fusion, especially multi-level fusion, you are buying adjacent segment disease, which can be around 25% in 10 years, according to the landmark paper of Hillebrand. So I don't think with fusion people are so happy as this lady from one of the Asian tribes. Of course, there is a bias when you talk about adjacent segment disease. Is it radiographic? Is it symptomatic? Is it operational? There are different definitions. And use of reoperation is probably the best way to define adjacent segment disease. Although we have to acknowledge that surgeons are less likely to revise and patients less likely to accept surgery if they believe that arthroplasty strongly reduces the incidence of adjacent segment disease. As you see here in this study, Prestige, 10 years follow-up, hypermobility did not occur at adjacent segments, though there is an effective protection of adjacent segment with an arthroplasty. This meta-analysis show less postoperative ASD incidence in arthroplasty compared to fusion. The number of second surgeries at the adjacent level are also significantly different in favor of arthroplasty compared with fusion. And you have to really follow up the patients because the incidence of second surgery at the adjacent level is follow-up dependent. For example, on this study, they look at the data 2 years, and there was no difference in adjacent level operation between the two options. But they extended the follow-up to 7 years and clearly less reoperations at the index level. Sorry, at the adjacent segment level. This is one case of mine, adjacent segment disease, as you can see here. Lady that I operated in 2014 as 5/6 and ACDF. This was her intraoperative viewing with a collapsed disc, and we were able to reformat the disc and insert a disc protest. So very good option when you have adjacent segment disease due to ACDF to insert an arthroplasty. And over the years, 68 months post-op, we see very nice mobility and nice alignment of this patient. And what you can also, of course, have as the option of hybrid surgery by doing an hybrid construct, which means adding a TDR to one level of fusion. You are limiting hypermobility. So you have also some benefit if you are doing hybrid surgery. And when you do hybrid surgery, it's very interesting to see that there is an increase of the range of motion of the prosthesis when coupled with the two-level fusion if you compare how the prothesis work when it is inserted standalone. So this is a very reactive technology. And you can apply hybrid surgery because you have different stages of disc disease. What I normally do is a fusion for a more spondylotic level or a less mobile or even hypermobile disc. And this is just an example, 45 years old female with an hybrid surgery. So what about cost effectiveness? There is this very interesting paper with AO Spine international members showing that they acknowledge that there was some benefit, but the cost of the implant played a big role in whether to offer it or no. And also in the US, surgeons acknowledge that if they do an arthroplasty, they perform an arthroplasty, there will be their reimbursement will be somehow affected. So in my country, I don't have this cost noise, which is a non-patient related factor. I'm not biased. The cost of an implant, of an arthroplasty implant or a cage with embedded screws and my reimbursement are similar. So I can offer this technology to the patients. And if you look at cost effectiveness, you have to look at complications and cervical spine fusion, 10 years outcome, secondary rate for surgery, quite high even for pseudoarthrosis. And if you leave multi-level, look at the tremendous numbers of figures of pseudoarthrosis that lead to reoperation when you do multi-level surgery. So again, this study from Prestige, long-term follow-up, second operations at the index level, much lower with the prosthesis than with the ACDF. And this is level 1 data with long-term follow-up. So taking data from the real world, large national insurance database in the US. So it's data from outside the IDE, it's real world patients. TDR is cheaper, 12%, and mainly because less incidence of reoperations. We have to acknowledge that higher overall hospital costs are a little bit higher, especially in other countries, not mine. Less reoperation, complication rate, increased return to work rates. So it's clearly a cost-effective surgery over the lifetime of a patient, obviously assuming 20-year prosthesis survival. Another study, 5 years follow-up, arthroplasty is highly cost-effective in two-level in long-term follow-up analysis, more than 5 years follow-up. So what about motion preservation? And you have to look at not only range of motion, but quality of motion. One study that we have done with my PhD student, 31 patients, different scenarios, multi-levels, hybrid constructs, and we use that spine view software to look at the motion, including the range of motion and the location of the center of rotation. It was interesting to see that the arthroplasty device reproduces the range of motion that you would normally expect on a normal spine is asymptomatic adults. So the same device is reacting differently according to the index level that was operated. There was an increase in global and range of motion, but really minor changes in adjacent levels motion. And what was very interesting to find is that the center of rotation location tends to be a little bit superior in posterior 6 months and only normalizes at 1 year. So it's only interesting to look at clinical data, in my opinion, after 1 year. That's when center of rotation location becomes to a normal position. You see here motion preservation, long-term follow-up, two-level disc arthroplasty, range of motion despite the occurrence of 43% of age. So there was an interesting preservation of the range of motion. As I said in my early starting, it's probably clinically more meaningful to offer this motion preservation technology in multi-level disease. It doesn't make any difference if you do 1 level or 2 level, the range of motion. So prosthesis will work the same as if you do 1 or multi-level implants. You don't lose performance. As you see also here, multi-level patients versus single-lesion patients, similar improvement on the range of motion. It seems also that the effectiveness, it's more apparent when you start to treat more and more patients, like here, more levels, like here, the 7-year follow-up, you see a clearly difference on when you're doing 2 levels compared to 1 level. 1 level here, 2 level TDR here. And the more you follow up the patients, the more superior clinical outcomes you see in multi-level patients. We have our own study that we look at the 21 patients operated 2 levels, 11 patients 3 or 4 level, 5-year period, consecutive cases, single surgeon, single device. Look at the mean age of our patients were quite young. Interesting follow-up. These were the levels that were operating, nothing new on this. But look how nice the global range of motion, delta, and the index level range of motion. And this is obviously in strike contrast with the complete loss of mobility when you do multi-level fusion. And if you split the patients on 2 level versus 3 and 4 level, you have the same performance of the prosthesis. And some of our patients, this is from one of our publications, where you can see very nice motion and of the patient. All this is very important, motion preservation, range and quality of motion, cost effectiveness. But what's the capacity of this technology to preserve and correct sagittal balance? This is the next step. And why is that? Because we all know that sagittal alignment, even though 1/3 of the patients of asymptomatic people can be not lordotic, we assume that there is a clear correlation between NDI and cervical lordosis. And any form of sagittal imbalance, kyphosis, increasing SVA leads to neck pain and myelopathy progression because you have more degeneration on the discs and on the facets. So we also did a study, 35 patients, look at the sagittal balance. These were the levels operated. There was a significant increase in the range of in the angulation of the index level, as you see here, significant, and also an improvement on global lordosis on cervical spine. And it was interesting to perceive that the increase in global lordosis derived essentially from the increase at the index level lordosis. Other meta-analyses also have shown that it's really interesting and possible to increase global alignment, sagittal balance with arthroplasty. And this is especially true in patients who have a low pre-op T1 slope. It's really helpful when you have those patients, it's easier. And if they have also kyphosis, it's easier in those patients to improve sagittal alignment. And also adjacent levels, you can have a good effect on alignment from performing an arthroplasty. As you see here, doesn't make any difference if you do single level, multi-level, you are achieving similar improvements in sagittal balance. This is again our study, and look at the multi-level, nice variation of lordosis, of the SVA, and improvement on the operated level. It doesn't make any difference if you do more or 2 or more, 3 or 4 levels. So it's clear that we have gains in sagittal balance with arthroplasty. So why kyphosis at index level is still widely recognized as a contraindication for arthroplasty? And I think this assumption mainly comes from the KIM study, where only 13% of pre-op kyphotic index levels became lordotic, whereas they could reverse global kyphosis in 1/3 of the patients. So it seems that arthroplasty works better on a global view than on index level. We look at our patients with kyphosis, identified 23 patients with 25 kyphotic levels. These were the levels operated. And there was in every single level, being kyphotic, pre-op kyphotic, there was a significant increase in segmental lordosis, as you can see here. So this is strikingly in contrast with the KIM paper results with, of course, also a different device. Increase in lordotic global angle, not significant, and a slight non-significant reduction on SVA. Here, just to show you one case with a kyphotic level, patient had 1 or 2 years ago, I can't remember well, also an X-ray that shows some degree of kyphosis here. It's not really clear related with pain or degenerative changes, but clearly you have here stenosis, you have this huge disc herniation. It was minus 13.2 degrees on this angle, 5/6, and it was flexible but not fully reducible. Even in extension, you have some degree of kyphosis. So we inserted two disc prostheses, and there was a remarkable increase on alignment, on lordosis, on the segmental level from almost 18.5 angulation, with a gain of range of motion, and as you see here, with a better sagittal alignment. And the center rotation of both prostheses were really nice, the location of the center of rotation. So sometimes you cannot just rely on the disc prosthesis itself, as you have here, this kind of kyphotic alignment. So we have to do some sort of osteotomy to have rebalance the spine, reformat the disc, the vertebra, and have this nice post-op day one balance, as you see here. And during the follow-up, very interesting follow-up. So what's the next step? How can we push forward the indications for arthroplasty? I believe most of the surgeons in the audience, they will consider a slit disc as a contraindication for arthroplasty. Again, kind of patients that we see with a jaw 14 limit sign, some dysesthesia, weakness, these kind of patients, and look at the age, they are quite younger. Almost a flat, non-lordotic neck, as you see here. This is how we do the operations. I don't use Casper retractor. I just use the section as a leverage maneuver to work on the disc space. And at the end of my surgery, I'll do this maneuver when I release everything, including the PLL. And if I feel that there is some motion, I consider the patient elective for an arthroplasty instead of a fusion. So look how nice the disc height increase from 2.6, in this case 4.5 to 6.6. So a 4 millimeter increase in the disc height with arthroplasty, with a good sagittal alignment, as you see here. So increase in disc height and good sagittal alignment with preservation of global and segmental range of motion. So preservation of range of motion, reformatting, gaining disc height, good sagittal alignment. That's why I think in multi-level disease, arthroplasty can be a window of opportunity to treat earlier patients with cervical radiculomyelopathy. And you don't, as you see here, an MRI, post-op MRI, you don't compromise decompression by using this technique. Again, another patient, multi-level disease. Instead of doing a fusion, look how close were, how tight were the discs. We had a very nice reformat of the disc. We look at patients with disc height less than 3 millimeters. We identified 28 patients, 39 pathological levels. The delta of the disc height was quite impressive. As you see here, around 5 millimeters gain on post-op angulation on the lordotic side, and also a good regaining of the range of motion. So I think that collapsed discs, by definition, less than 3 millimeters are amenable to arthroplasty if you use the compressible 6 degree of freedom devices. And it was interesting to see that there was a relation between the more collapsed discs gain more disc height, and also somehow less mobile discs gain more range of motion. And finally, what I think is the most compelling argument for arthroplasty, it's the compensatory mechanisms while you are aging. And this is very important imaging you have here. While you are aging, you tend to increase your cervical SVA. And what's happening? There is an hyperextension at C0, C1, C2, and a compensatory flexion of C2, C7. Let's, for example, have a look to this patient. These are the films, the flexion extension. We have also flexion extension MRI, something that we do to assess the number of levels that need to be decompressed. And this is what we have done to the patient for level arthroplasty. And as you see here, over the years, we are able to allow for the spine to accommodate different lordotic angles, different SVAs, always preserving the range of motion, as you see here. Another unconventional case with a idiopathic hyperostosis patient here with this kind of dish situation. We operated the patient, index level range of motion preservation, as you see here. Dish disappeared. We have a 7 years follow-up for this patient. And over time, there were loss of segmental lordosis, but this prote is immobile. So these are the kind of situations that happen in patients. And if you do a fusion, you are aborting this compensatory biomechanical effect that patients need along their lives. Another situation here, and as you see here, range of motion preservation coupled with positive sagittal balance, 7-8 years follow-up, and look at the variations. If you do a fusion, you end up not having this chance of having these compensatory mechanisms working on. So this is the future, I believe. These are some of the expanded indications we published in Neurosurgical Clinic of North America, book chapters also on different papers. And I invite you to read those papers. You can find more information about technique and indications. Of course, I'm not a fundamentalist of arthroplasty. I acknowledge there are contraindications, and many of these are related with the facet joint arthropathy that you can see on MRI, whenever there is large osteophytes on CT, arthropathy, OPLL, of course, huge kyphotic deformities, hypermobility, and the usual contraindications like infection, severe osteoporosis. So I believe that in multi-level disc disease, each individual level can be considered for arthroplasty, but you have to carefully scrutinize to identify contraindications. It's important patient selection and to respect those contraindications. Briefly also, if you look at, I think the future will be more work in biomechanics of the devices. As you see here, there is a change in location of the center of rotation according to the level of spine that C3 is different from C6, C7. And if you think we are using the same implants, no matter what level we are operating. So I think the future will be also some form of customizing the center of rotation of the disc prothesis to the level we are operating or to the level of degeneration that we have. Also, age produces changes in the location of the center of rotation. So expanded clinical indications will come along with different changes in design of those implants. So in conclusion, I think arthroplasty mitigates negative biomechanical effects of ACDF. In long-term follow-ups that we never have available shows superior clinical outcome, less reoperation, higher cost utility. When you do multi-level, you are amplifying the beneficial effects compared to single level. It promotes positive sagittal balance and shows the capacity to reverse global and segmental kyphosis. It's a reliable technique in unconventional cases like the collapsed disc that I showed you. and certainly can be a window of opportunity to treat younger patients, and as compensatory mechanisms are preserved, contrary to when you are performing a fusion surgery. And of course, I hope the future will bring also improvements on design of the prosthesis. Thank you.
Thank you very much. That was an excellent talk. And I think what was helpful is that there's so many great illustrative cases. We have several questions in the chat box, and I encourage anyone who's on the webinar to please post your questions. I do have one question. I think it's very interesting when you hear a speaker on arthroplasty, when you talk about sort of bias and financial constraints, whether it's, individual or the hospital or the system. I think that is a major issue. I think we can all acknowledge with arthroplasty, especially in the United States, but it's interesting to hear other global perspectives. And I think that certainly within my own practice, we'll do 1 or 2 level disc arthroplasty. And I'm curious because you showed really great examples of 3 levels. And I'm curious when you see a patient with those MRIs, and let's say you're considering 2 versus 3 levels, is there a threshold, I think, radiographically on the MRI with that other level that tips you more to including that or observing it? Let's say if it's central canal stenosis or foraminal stenosis, because I have the same problem sort of thinking through that when I'm thinking about like ACDF, like you see radiographic degeneration, but maybe they're not symptomatic from it. And you're thinking, well, maybe I'll just hedge my bets and just take care of it now, preemptively,
Right.
So I'm wondering, is it, when you see something, is it like you're thinking, oh, there's some moderate stenosis or foraminal stenosis? Like, I think that'd be really helpful. I'm curious your thoughts.
Right. No, I mean, it's a great question. I think the Hillebrand paper that we all know very well by heart clearly shows that most, or at least a substantial number of the adjacent segment disease were already degenerated discs at the time of the operation. So taking that in consideration, I think this is very powerful data. Whenever you see some degree of degeneration of compression, I'm not talking about minor disc degeneration. I think you should include in the initial construct, in the initial surgery. And it's always not very pleasant to reopen again, and the neck, its morbidity is increased. If dysphagia, you risk much more complications when you are reopening a neck for a redo surgery. So if there is a substantial radiographic appearance, I tend to include in the index surgery. On the other hand, also, you have to acknowledge that some 33% of patients, 1 in 3, what you see in radiology, it's not where the clinical symptoms are. So when you see multi-level disease in radiology, in MRIs, you don't know where exactly the pain, the radicular pain comes from. And there are a lot of studies showing that you can have prefix or postfix brachial plexus, all this plays a role. So to play on the safe side, probably better to include everything on a single procedure.
Right. And I also, as a follow-up, I really loved your video where you showed, the decompression and how you do that maneuver to kind of see the mobility, flexibility there. And, my question is, I think from a technical standpoint, do you do anything differently in terms of the extent of foraminal decompression or how much of the uncinate, let's say you maybe drill off, or in that, by the pedicle, when you're doing a arthroplasty versus ACDF, in terms of thinking, well, like maybe I don't have to do as much, or maybe I have to do more. I'm just curious your thoughts on that.
Yeah, another great question. I just came yesterday evening from our CSRS Europe meeting, and there was a lecture from the president of CSRS Asia Pacific on failures of arthroplasty. And I have to tell you that 90% or more of these failures were operated by another guys, of course, but insufficient decompressions, okay? Which for me, it's not a failure of the technique. So this is addressing to your question. I think first you have to do a proper decompression. You cannot rely on indirect decompression when you are doing an ACDF, okay? ACDF, you don't need to be so exhaustive. You will gain height. There will be indirect decompression. Patients will do well. Here, you have to do exactly, meticulous decompression. And in my opinion, also go a little beyond the compression because, patients, especially in lateral bending, if you are not perfect, they can have some arm pain when they are in the extremes of lateral bending. So I think that's you should be careful. You should be an experienced surgeon if you want to have good results with arthroplasty. Okay, it's not like doing something, put a cage, increase height, and the surgery it's done. The other thing I always advise you to do is remove the PLL. PLL, I don't see another way of removing osteophytes, of doing a proper decompression if you don't go underneath the PLL. You need to resect the osteophytes. You cannot get into between the OPLL and the osteophyte. That's not possible. You have to go under. So that's one reason. And the other one is if you remove the PLL, you are abolishing some sort of scaffold for heterotopic ossification. Okay, if you leave the PLL, for sure you will have high percentages of heterotopic ossification.
Right. No, that's excellent. And I think that, again, I really enjoyed seeing the cases and you taking us through that. And, there was one case where you showed doing a little bit of osteotomy to get that segmental lordosis, which I think is really fantastic. And it's really interesting. My question is, especially in that technique, I think like I'm always worried about like the bone quality and, maybe in this patient population, because they tend to be younger, maybe not so much, but, when you're doing so many levels and you're sort of, creating more lordosis where you showed that maybe when they start, they're a little straight. Are you worried about subsidence or is there some way that you're thinking about, something about your technique where you're trying to reduce the likelihood of that?
Yeah, I mean, I think if you're doing arthroplasty, another thing that you have to bring in mind is have to do a very generous discectomy and be able to use the biggest device that you can have to have a good end plate coverage. Okay, this is very interesting strategy to reduce also HO and also to avoid subsidence.
Right.
Honestly, we don't have much subsidence. I don't see it much, contrary to ACDF. I think one of the reasons are these kind of proteins that they have a compressible capacity. So even though at the beginning they are probably a little bit height, with time they compress and they adjust a little bit. So it's not something as strong as a cage, that it cannot be reducible in height. And it will favor subsidence if it is overcrowded, let's say, overstuffed. And also this compressibility of the proteins also protects a little bit the facet joints on the back. So we don't see subsidence, honestly, with the third generation implants.
Well, that's fascinating, and I think we have several questions from the chat box, but they're all somewhat related. And I believe, you discussed the clinical outcomes between ACDF and arthroplasty in your talk. There was a very good figure that you referred to. There's one question about your experience with adjacent level disease after arthroplasty, and your need to either revise or operate on that adjacent level. In your experience, what have you found?
I mean, that's really a good question. And, we tend to follow up the patients. We are interested in this technology, so I have long-term follow-ups for the patients. And honestly, I can remember one case where we have to an adjacent segment disease after an arthroplasty. Of course, one reason is probably because we include already in the index operation the level that was already not so in so good condition, but we don't see it as often as with ACDF. By far, it's much less. And in my experience, doing high volume of arthroplasty, since 2011, I can probably remember 1 or 2 cases of adjacent segment disease.
And do you have a maximum number of levels that you would consider, or
We have done some cases of 4 levels, but this is very unusual. I mean, it's very unusual for the patient to have 4 levels that need to be done an arthroplasty, and most of those patients probably will end up with hybrid constructs because different levels will have different levels of degeneration. So you might consider a fusion in lost discs or not so mobile discs.
Right. Well, I think those are all the questions we have, unless there are other questions from the panel or any of the other attendees.
So far, none. I think we can wind up the first session.
Okay.
Great.
Thank you so much. It was a great pleasure, great honor.
Thank you very much, everyone. Thank you for joining us.
Thank you.
Well, thank you very much, Prof. Oscar Alves and Prof. John Chin, for this exciting session. We'll move on to the second session. Before that, I'd like to inform our viewers that this has been broadcasted on WeChat, YouTube, and Zoom, and as of now, we have around 460 people who have joined through different channels in different parts of the world. So we have a very interesting webinar. I'd like to hand over this podium to our second chair, Prof. Ali Riza, to say a short introduction and invite Prof. Ming Li.
Thank you very much, Raja, and thanks very much for the Asian CNS for inviting me. It's an honor to introduce Professor Ming Li, who will be talking about this talk being prediction of IDH mutation status in WHO grade 2 and 3 glioma using a combination of hyperintense flare signal at the rim of the tumor combined with H1 MR spectroscopy. I think this is super exciting. We're all striving in different ways to have minimally invasive or non-invasive means of determining the grade of the tumor or IDH mutation status. Particularly exciting times, given that we're having drugs such as IDH inhibitors potentially holding promise. So exciting to hear this talk. Looking forward to it, and looking forward to the discussion that will spawn after this. Professor Lee, go ahead, take it away.
Thank you, Professor Riza. This is the project we did during last year, and this is my master student finished that. This is a project makes maybe looks not a very high level, but this is very convenient and easy for some small hospital or in the developing countries. The title is how to predict the IDH mutated status in glioma. We use a very simple way to test. We establish the model. I'm mainly from China. Here is China. You can see this is China. This is our province. Our province is 1 million, 100 million people in our province. And this is my city. This is Yellow River. Our city is located nearby the Yellow River. This is Shaolin Temple in my hometown. This is our hospital. Our 3 hospital is one of the largest hospital in the world. Right now we have the 10,000 beds right now in our hospital. Actually, our neurosurgery department is 300 beds right now. I think it's also the biggest department in China. So firstly, I introduce the background. This IDH status is very important right now. We know at least for astroglioma, nearly 70% is IDH mutant. And oligodendroglioma is also nearly 70%. For glioblastoma, primary glioblastoma, nearly 3 or 5% are IDH mutant. For secondary glioblastoma, nearly more than 80%. IDH is very, very important right now, and you have a significant clinical aspect. Right now, there are several ways to test IDH mutation, and antibody test, single sequence MRS, 2GG test, and mass spectrum. How to treat IDH mutation? There are some IDH inhibitors, IDH vaccines, NAMT inhibitors, glutamine synthesis inhibitors. Last year, the New England Journal of Medicine published this paper. This IDH inhibitors can significantly improve the progression-free survival of low-grade IDH mutant gliomas, underscoring the importance of non-invasive assessment of the IDH mutation for clinical significance. WHO graded and molecular types of IDH adult diffuse gliomas. They based on the IDH mutation and 1p19 co-deletion status. IDH mutation with 1p19 co-deletion, IDH mutation without 1p19 co-deletion, no IDH mutation. The last tab is with, I think this is IDH wild type. IDH is very important. We can see the survival is significant. If you have the IDH mutation, the people will have a good survival. So how to use the conventional MRI to predict the IDH status pre-operatively is one of the significant clinical importance. Actually, I know in US, most hospitals have the 2GG spectrum. But in many countries, in many hospitals, they don't have the 2GG spectrum. How to use the a simple MRI to predict IDH status? That's my team to focus on. So this is first we introduce what's the T2 flare mismatch sign. T2 flare mismatch sign is a completely or nearly completely uniform high signal on T2, and the flare should low signal. Strict exclusion criteria: necrosis cavity, small sizes, no enhancement. To avoid potential misjudgment, we don't use the T2 flare mismatch sign for the pediatric patients, or use just a or in T2 coptic green matters within the tumor maybe show relative low signals. We should exclude these patients. So this paper, T2 flare mismatch sign, was published by my collaborator, Professor Taraka from Germany. He said that if we diagnose IDH mutant stroma using the 3 combined parameters, the patient under age 14, tumor larger more than 6 cm in diameters, displaying T2 flare mismatch sign. Specifically, sensitivity and PPV are 94%, 27%, and 88% respectively. So this is a typical standard T2 flare mismatch sign. If we saw this sign, we think, oh, this is IDH mutation. If we can see here, it's a high uniform T2 signal, but it's a low signal on flare. So we decided this is a T2 flare mismatch sign. This is a typically standard. This is the exclude. If the tumor has some small low signal area in flare sign, just like this one, we will exclude this T2 flare mismatch sign. And if the tumor displays homogeneous high signal on T2, as the T2 signal looks not uniform, we will also exclude this one. And this patient we can see have the uniform high signal on T2, but on flare there's some clear low signal. So we also exclude this T2 flare mismatch SAM. And this is a cortical green matters. This we will exclude this one. So what's the mechanism for T2 mismatch SAM? There are several literatures to explain. Some said they have the macrocytosic changes. Some people said that this is have a close correlation. Some people said that, and another professor, Deguch, is just 8 cases beside there's a significant collaboration. Genetically, some people said T2 flare missense are closely associated with motor pathway. This is a typical pictures. So what's the T2 flare missense of versus hyperflammatory? This is from here we can see A and B. A is a high T2 flare. B have the low flare sign. So this is the T2 flare missense sign. For C and D, we can see, especially D, we can have this closely high circle of the hyperflare rim. This is we call this hyperflare rim sign. We will use the application of MRS in gliomas. MRS is a non-invasive image muscles that reflect a concentration of metabolisms. From here, we found the CHO, NA, and the CR. Those MRS data. Both CGO and the CGO to CR ratio are positively close correlation with the grade of the tumor. So this is the project that we conduct in our hospital and another hospital, 2 hospitals. We retrospective the cases from the 2018 to 2023. Inclusion criteria meet the diagnosis criteria of the glioma. All patients underwent the surgical treatment and obtained post-operative pathological results and molecular diagnosis results. The patients underwent pre-operative MRI, MRS, and CT examination with the collaborated data. Excluded data, exclusion criteria receives the unconservative treatment. MRI image quality was poor and can't be studied and analyzed completely with others neurological diseases such as cerebral infrastructure, cerebral hemorrhagia. We have the 2 group, test group and the violation group. Test group, we first immediate criteria of patients larger tumor diameters, primary brain lobe involved, whether it's closed midline, presence of the pre-tumor, clarity of the borders, and the presence of the enhanced rim. T2 flare mismatch of hyper-rim flare. And the MRS indicators, we use MAA to CR, CHO to CR, CHO to NAA. And we analyze whether the basic indicator of the above the patient have the significance. And the violation group, we also have 1 group for violation. So violation, the AUC accuracy, sensitivity, and specificity of the mentioned model. Result from our project, we found that the most IDH mutant patient mutant patient are for IDH. We can see most IDH glioma grade 2 and 3. Tumor fluctuations frontal, some are frontal, some are non-frontal. For wild type, frontal is for wild type. Most of our basic was located the non-frontal. For diameters, we found the IDH mutant have the high diameters, large tumor. And adenoma for most IDH mutant have the adenoma. And tumor border, we can see the IDH mutant mostly have the clear tumor border. Rim enhancement, we can see IDH mutant have the rim enhancement. T2 flare mismatch sign, we can see IDH mutant mostly have the IDH T2 flare mismatch sign. Hyperflare rim also have the IDH mutant have the hyperflare rim. For MRI indicator, we can see for IDH mutant, CTO2NA have the data looks larger than IDH wild type, and CTO2CR and the NA to CR. So the result, we can see the cutoff value of CTO2NA is 3.29. AUC is 0.81. Sensitivity is 60, 0.6. Specialty is 0.9. For CTO2CR, the cutoff value is 1.8. Sensitivity is 0.6. Specialty is 0.7. Largest 2 meters is cutoff value is 4 cm. This is the model that we try to establish. If we met people in the outpatient, we see this is a 2 or 3 the grade. Even exclude as a glioblastoma. If we have the hyperflare rim or calcification, if we saw hyperflare rim or calcification, we think this is the IDH mutant. Even though hyperflare rim or calcification, if the tumor meter diameter is more than 4 cm, and if any condition or meters CTO2NA is more than 3.2, and the CTO2CR is more than 0.8. If we met this, we think this is the IDH mutant. And otherwise, this is the IDH wild type. The test group also shows us this is sensitivity is 0.8, specialty is 0.9. And the variation group, we found the sensitivity is 0.9, specialty is 0.91. So this is the model. Think we try variation group also think this is model is very useful. Okay, I will see. So this is we compare the T2 flare mismatch sign versus hyperflare rim sign. In our study, we found the T2 flare mismatch sign only have the 18 patients, and the hyperflare rim we have 23. Compared with the T2 flare mismatch sign, hyperflare rim have a higher sensitivity in diagnosis in defining IDH mutant. And the CTO2 NA ratio and the CTO2 CRI ratio can serve as a really reliable quantitative information provided the clinical prediction. So CTO2 CR ratio is also very useful for this project. So some typical cases that we wanted to show. From here, we can see this have the typical high T2 signal and the low flare rim. So this T2 flare mismatch sense. So we think, oh, this is a IDH mutant. This is another cases we can see even same classical example IDH with T2 high T2 and low flare. And so this is a T2 flare mismatch sense. So this is okay. If we met a patient like this one, oh, this is IDH mutant. We don't. It's not necessary to do the 2EG test. And this is also a classic of the hyperflame rim. We can see this picture. We can see hyperflame rim. If we saw this one, oh, this is the IDH mutation patient. This is the classification. Use our model. We can see if we met with a hyperrim, flare rim, or classification. This is IDH mutation. So this is also a typical cases use our model. Conclusion: if we use hyperflame rim, it's a specific and more sensitive marker for diagnosis IDH mutation, IDH mutant astrocytoma. MRI indicators CTO2 NAA and the CTO2 CR can predict IDH mutation in low-grade gliomas, but we must exclude high-grade. For the glioblastoma, we must exclude that one. This predictive model for IDH mutation constructed by combining the high flame rim signal, high flame rim classification, large tumor diameters, CTO to AA and the CTO to CR ratios can accurately predict the IDH status of gliomas pre-operative, thus can guiding the diagnostic and treatment plans. So this is my team. Thanks.
Thank you so much, Professor. That was a great talk. Really enjoyed it. Any questions from the audience? I don't see any in the chat.
And Prof. Mathuria wants to ask. Yes, Prof.
Say if the T2 flare mismatch and T2 hyperintense rim, if both these are present, is there still a need of magnetic resonance spectroscopy? Because that will add to the cost.
Actually, maybe 2 or 3 years, some research group will focus on T2 mismatch sign. I think people use this T2 mismatch sign. They use the 2EG spectrum to confirm that. But we use another, this one, hyperflame rim sign. This is we develop this sign, developed by our group. But I think it's more sensitive. But we use, so we ask one master student to do this one. But I think maybe hyperflame rim will be more easy and more accurate. And this is a model. We just use one of the model. I think the model is, if we met the people with a hyperflame rim and the classification, this is the IDH mutation. I think this is, and if not, we should use some MRS data to predict. But I think I don't know. I know many hospitals don't have the 2GG spectrum. In China, I know only one or two hospitals have the 2GG spectrum. I think maybe USA have more. I think Pennsylvania State University have the 2GG spectrum. Is it Professor Ali Rizada?
It's not commonly used, but yes, it is available. But I also had the same question. If we go over your data, it looks like if they have the mismatch and they have the hyperintense flare rim, all the cases of IDH mutation are detected in the 0 cases of no IDH detection, and that's without the need for MR spectroscopy. So I think the last question was, if we just have that without any spectroscopy, do we need to move on to spectroscopy?
Okay. But that means that's not a regular test for clinical in your department.
No, we don't use that. But the question was, would you recommend that we still go ahead with spectroscopy or stop at the regular MRI because it adds cost and time and interpretation challenges?
Yes, sir. So I think, but we try to make some. We try to do some single cell or to single cell sequence to find the mechanism of T2 mismatch sign. Right now we are doing some single cell sequence for this one.
Okay.
Yeah.
I guess right away, this is great, and assuming it's validated more on a wider scale, how would you clinically apply this information? Assuming this is globally validated, et cetera, how would you recommend that we clinically apply this information? It's great to know with imaging that there's IDH mutation. We're still going to biopsy and get molecular confirmation. But prior to us biopsying this, how do you recommend now that we use this information as surgeons or oncologists?
That's I think this model just for auto patient. But if we wanted to confirm the IDH status, we should have the pathology.
No, but presumably you did this imaging to this model construction to potentially one day avoid a biopsy, right?
Yeah, finally we should do biopsy. That's final data. But we can, but you might people on the auto patient. Oh, if we just a regular MRI, we can predict. We can tell them. We can provide more information for patient in auto patient. I think this is the but with this model can't replace the biopsy.
I'm hoping one day it can.
Even the 2GG spectrum, they can't replace the pathology.
Why are we doing it?
Yes, that's what
we just develop. This is a way to predict. This is just a way.
What comes to my mind, for example, if these IDH inhibitors start making their way to the clinic, that's one way of avoiding a biopsy, and starting with that first. A lot of people who are hesitant towards going ahead with surgery, let's say their tumor was incidentally identified, they're not symptomatic, and then there's also some data that suggests IDH wild type versus mutant, there's a different survival advantage to aggressive resection. So you may be able to tailor your surgical plan ahead of time. That's what I'm thinking. One challenge that the new, not so much new anymore, the 2021 WHO classification introduces is that we now have astrocytoma grade 4 IDH mutated. It's not and but potentially based on a molecular classification of GBM, you could have in theory a non-enhancing tumor that is astrocytoma IDH mutated grade 4.
Yeah, sorry. I know that's a classification right now. New version of the classification.
Yeah, that's fine. It's just that do you anticipate that potentially being a problem? Is that one added rationale to include the MR spectroscopy, perhaps? I'm just thinking out loud that's one other factor to consider. I think we're still looking at it like non-enhancing tumor ending up astrocytoma grade 4 IDH mutated. to be determined, but in theory, that could be a possibility. The other question I had about your model, the diameter. I feel like, diameter could be tricky because it's all a matter of when they present and, when you found them. What did you guys have any coefficient to, odds ratios or something I know you said you had the AUC, to gauge the impact, the strength, the statistical strength of diameter on your model? And I didn't catch it. Did you have a model that combined all these parameters? The MR spectrum. You did, right?
Yeah, we have the model. You let me show you again. Yeah, this one. If we met the patient, we looks like exclude the glioblastoma. You have the hyperflammatory or calcification. Oh, this is IDH mutant. I think.
Right, but did you have the AU receiver under operating curves for combining all these? Did you have that?
This is combining the MRS data here. This paper is under review. I think is under review. We will publish soon this paper.
Looking forward to it. Thank you.
Yeah, but I think that this is just a simple way and to use a regular MRI to predict IDH status during the outpatient department, and especially in some hospitals don't have the 2GG spectrum.
Yeah.
Yeah.
Was this 3T or 1.5T? Curiosity.
1.5.
1.5.
This being a more wide imaging could avoid the focal sampling of biopsies, avoiding undersampling, right? That's the purpose as well. Because when you're doing a biopsy, you are collecting a very small size of tissue. So you could avoid undersampling with all the implications of undersampling. Looks very interesting.
Okay.
Looks very interesting.
Okay.
I think the consensus is there's a lot of promise to your work.
Yeah.
But this is just because my research team have the nearly 10 PDD of master students. This is just one master student work. We focus on the glioma or IDH mutant, some spatial transcription, just like that. Yeah. And the IDH inhibitor, just like that. Yeah, we can sometimes we focus on the metabolism of one team most of them.
Yes, I think thank you very much. Clinical applications are tremendous. We hope to have newer things which come up in support of your very wonderful work. So thank you, Prof. Ali Riza Manzoori, for this session, and also Prof. Ming Lee. I would close this officially now on behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kato. I would like to thank both speakers of today, Prof. Oscar Alves and Prof. Ming Lee, as well as the chairs, Prof. Ali Riza Manzoori and Prof. John Shin, for their time and support for the ACNS webinars. A very special thanks to Prof. Shubin for broadcasting this webinar on the WeChat channel. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.